on first. Okay. Lectures that we've had this morning. And you've covered a whole field of Class 2 orthodontics already, looking at the next generation of orthodontics with what we heard from Dr. Garino this morning, looking at the scientific approach that we need to have in our profession from Professor Peltomaki and Dalia Latkowskina showing us most impressive orthodontic mechanics and clinical results with very good scientific support in what she does. I'm now left with doing something where we're going to go back and doing not non-compliance, which is completely right. We have a problem with compliance in our patients, but sometimes we forfeit something in our treatments if we do non-compliance. Is a very much forward downward growth phase that we know of. This has been described to us by many different orthodontic fields all over the world, but we need to remember that this needs to happen to a face, and we need to make it able. We need to simplify what we do so that this kind of growth can happen, so that the process of the face can go into this kind of development. So looking at Class 2 cases, before we look at Class 2 specifically, I want to clarify the issue that we are looking at Class 2s sometimes that are Class 1s. Now we know by Martin Dewey from 1950 that he put Class 1s into 4 different types, and 2 of these types are often confused with. And we can see this if we look at their OPTs here, that the shape and size of the condyles and the glenoid fossas differ and vary from patient to patient. Here we can see the glenoid fossa of the Class 2 patient, and significant to what I was saying about the forward motion of the mandible, it is a steep glenoid or condylar plane that we see on the Class 2 patient, especially comparing it with a Class 3 patient where we see hardly any steepness in the condylar plane. So if we looked or compared what is going on in the formation of the coronoid process in comparison to what happens on the condyle, because treating a Class 2 patient that is skeletally Class 2 is to me something different to treating a skeletal Class 1 with a dental-alveolar Class 2 situation. So in the end, looking at these, I think looking at skeletal patients, I would summarize that they have elongated lower facial heights, they have more than 10 degrees of a mandibular rotation that we need to correct. We need to look at the severe protrusion of lower incisors, and we have protrusion over eruption of upper incisors. We heard all of this morning from the colleagues, from the esteemed colleagues that did their lectures this morning. And of course we have severely underdeveloped posterior facial height, which is what I was talking about when I said the ramus needs to do a lot of growing. Dental alveolar is pretty much that we need to look at the sagittal. We don't want to look at Class 2s purely from a two-dimensional direction. We need to consider it in a three-dimensional orientation. So we need to look at incisors. We need to look at the transverse, and we need to look at the vertical, which is the occlusal plane. So we're looking in the 3 dimensions, X, Y, and Z axis, and how do we treat these 3 areas? Now, first of all, the incisor is pretty easy. To let a mandible go into this anterior-rotational growth, I need to open up the maxilla. Now, this might be contrary to what we think in Class 2 treatments, where we want to reduce maxillary overjet. But I think what we want to do is we want to increase mandibular rotation. Because reducing maxillary overjet, collapsed buccal segments, narrow arches. Now, if we don't correct that, we're not really going to get out of a class 2 because it just cannot fit. So we need to derotate those molars, and we saw a very impressive presentation of how a Herbst can do that. We need to upright buccal segments. We need to allow an intercanine width that is relative and congruent with the lower intercanine width for the incisors then to be in a correct position relative to the arch shape. And now we have a congruent arch shape in the maxilla so that the mandible can actually fit the picture. Of course, when you see this, it looks like I've retracted upper incisors, but remember, we're talking about a growing patient, so everything is coming forward in the end. As we were shown as well, very significant, but it is unfortunately compliance dependent. But this is the clue of getting skeletal class 2s into a skeletal class 1. I need to have a disarticulation to allow the facial growth in the posterior segment, and by doing the following, by using very low force elastics that I apply here, patient is mostly in a free way, that means he's not in occlusion most of the day. We have a slight trigger motion by the canine pulling back the molars, the premolars and the molars, and we have the eruption phase of the molar that we saw very beautifully on Professor Poltamaki's lecture this morning through the different age groups, the molar erupting and erupting. Now I want to stimulate this molar eruption to allow the mandibular rotation into that forward growth pattern. Treatment. It doesn't help him one bit. He doesn't look good, and he has TMD issues. So doing his treatment was opening up the incisor, proclining that incisor, and correcting the occlusal plane, which we will be looking at, and then giving him a much more anterior rotation of the mandible, allowing that tertiary vertical mandibular growth that we expect to see post-eruption. Now the torques are important for maintaining the nasolabial angle, and it's becoming more and more important because our patients want to have a beautiful face, and this is very much part of it, is keeping their upper lip in position. So we want those 108 degrees, and I'm going to show you 15 different on the 7 buccal, the buccal cusp occlusal surface that we have bonded here to allow an occlusal eruption rather than a tipping that we would have if we had placed the appliance buccally. At the same time, by doing the class 2 mechanics on the maxilla, we're giving the arch a bit more space for that canine to come into, and this is what you will be seeing happening here. So we have a symmetry of the arch at this point in time. We bond the lower teeth. 7s have erupted at this point in time. We're using very low force class 2 elastics, more of a box shape class 2, and coming into a good class 1 occlusion as we finish off in his treatment. Congruent maxilla to mandible. And at the end of treatment, this is the result we have. 22 months of treatment, and he's in a class 1 occlusion. He still needs to settle a bit on the left-hand side, on the right-hand side, and he still needs the 7 to erupt fully into position on his left-hand side. But this is where he started, this is where he ends, and this is the change of the maxilla. Now the change of the maxilla is the clue to the treatment, because the mandible would not have had a chance to fit in and to rotate into this position if we had not allowed this maxilla to do this kind of development to shape into the congruent form of the mandible. And this is our planning. This is where we came from. This is the overlay in the background there.